Markers, becoming big business, right? Everybody wants to know if they've got cancer, okay? Big business. So when I started doing this lecture, there wasn't a whole lot out there. And I was looking and looking and looking, and your book didn't have a whole lot. And so I actually went to a continuing education training in Chicago. I was so tickled to go because it was on tumor markers. And lo and behold, he didn't have anything for me that was more than what I had in your lectures. So there's really not a whole lot out there. A true, and we'll get into this, I'm just kind of giving you an overview, but a true tumor marker, it's kind of like when you know, HCG with your pregnancy, right? You want to know that you're pregnant. So with a tumor marker, you want to know what it is that you've got, right? Not only that, but you also want to know how bad it is. Don't you want to know how pregnant you are, right? Am I 2 weeks, 5 weeks, 15 weeks, right? So is my tumor little bitty and I'm okay, or is my tumor huge and I'm going to die, right? So tumor markers are important because one, we got to figure out what you got, and two, we got to stage it. We got to figure out how aggressive we need to be to treat it. So that's kind of the theory behind tumor markers. So your cancer tumors really are uncontrolled, rapidly dividing cells. That's why chemotherapy works, because it attacks rapidly dividing cells. That's why people who are on chemo tend to lose their hair and things like that, because those are rapidly changing cells, and you know, chemo just kind of wipes you out from that. So you have some, on slide 3, it's just basically some definitions for you. Metastasis is the spreading of the tumor, because sometimes you'll hear that, oh, I had a tumor in my liver, but it metastasized to my brain, or I had, and they can tell, that's really interesting to me, is that they can tell where it came from. So if they find it in your liver, but they can go, oh shoot, no, this was really a GI tumor, so then they go and look for it there. So it's kind of interesting. They can find that, you know, because sometimes breast cancer didn't really start in the breast, it may have started somewhere else. Or it did start in the breast, but then metastasized somewhere else. And then the origin can kind of go with it. It's kind of interesting. So on number 4. So properties or characteristics of an ideal tumor. Cellular characteristics or substances produced by the cancer cells that differentiate tumor cells from normal cells. Makes sense, right? You want to make sure that that cell is truly a cancer cell and not just a normal cell that went cooking. Specific for a single type of cancer. Now, wouldn't that be nice? Yes, ma'am.
What's the difference between a cancer cell and a normal cell that we're cooking? Because I thought that's what a cancer cell was. A normal cell that just doesn't do what it's supposed to do.
No, not, it mutates. It's different. They don't look the same. They don't act the same. They're way
There is a
different.
genetic mutation in it.
Yeah. So specific for a single type of cancer. Again, if you've got toe cancer, we don't want to confuse that with finger cancer, right? So if we do a blood test for toe cancer, we don't want to, you know, cut off the finger by mistake. Absent in healthy tissue. Very important, right? Because if we're going to screen you, if we're going to draw your blood, and we're going to screen you for a cancer, we don't want them to be absent in healthy tissue, right? We don't want false positives, right? So they've actually stopped doing some cancer tests simply because they were getting more false positives than they were getting accurate tests. So they were doing a lot of biopsies for nothing. So that's a lot that's come about too. For PSA is a big one, for the prostate, PSA. They actually don't even want to screen men anymore after the age of 65 because they were getting so many false positives that they were doing a lot of biopsies and a lot of more young people for no reason. So, high sensitivity for cancerous growth. Makes sense, right? If I've got a tumor and it's growing, do I not want my level to get higher as the tumor gets bigger? So that I can find out whether or not it's going anywhere. Make sense? Right? And a short half-life of the marker in circulation. So what does that mean? If I do surgery and I remove your tumor, do I not want that tumor marker to drop rapidly, to get out of your blood quickly, to know whether or not I got it all? Okay. There is a test we do in the laboratory called PTH, parathyroid hormone. Okay. If you have a high parathyroid problem, your level could be, let's say, 600. The doctor will take you in for surgery, remove your parathyroid gland. Those are those 4 little glands that are kind of like, if you think of your thyroid kind of as a bow tie, it's like the 4 little tips of the bow tie. The doctor goes into surgery, removes your parathyroid gland. Your level will drop by half within 20 minutes. So they're going to draw blood before your surgery, and your level's 300. He's going to remove what he thinks he's got. They're going to wait 20 minutes. They're going to draw the blood. They're going to leave the patient wide open. They're going to run down to the lab, hand you a specimen, stand there and breathe down your neck while that specimen runs. And as soon as he has a level that's half, then he knows he got it all, gets on the phone and says, okay, close him up. Okay, so a lot of them are very important. So usually they are scheduled. You know they're coming down to the lab because you want to have your machine up, you want to have your reagent on your machine, you want your quality control done. So all you have to do is when that tube comes down, put it on push go. Because he's going to stand there breathing down your neck waiting for the result. We had one doctor, I used to hate him, because the time on the machine was always like 2 minutes different than the time on the wall. And so the machine would say it's going to be done at this time, but he'd be looking at the clock, and then he'd be like really antsy because it wasn't exactly. I mean, he was that anal about it, you know. It's just, and if he didn't get it all, then he'd be really angry because he didn't get it. That's the nature of our job. Yay. Okay. So, final fact: screening in healthy populations. Again, are we just going to screen people just for hoots and hollers? If you're asymptomatic, there's no point, right? Now, obviously, we feel something or we think something's incorrect. Yes, we will. But again, we don't want false negatives or false positives. I'm sorry. Okay. Monitoring asymptomatic patients again for diagnosis, to follow up to a treatment. So if we've treated you with chemo. Nowadays, I've noticed that they're not all that gung-ho on going in for surgery. That they tend to try to shrink it with radiation or shrink it with chemotherapy so that they don't have to take as much these days. So the thinking has kind of changed. It used to be, oh, you had a tumor, let's just go and remove it, and then we're going to zap what you've got left. But a lot of that thinking is kind of changing. And then again, most tumor markers will fit that category for monitoring symptoms of patients versus just running it on somebody just for the hoots and hollers. It'd be nice. I mean, you can go in and every year when you do your annual checkup, they check your blood sugar and everything else, and they're going to screen you for 15 cancers. But really? Do you really know? That's good. So tumor marker types, hormones, oncofetal genes, fetal proteins, and enzymes. We'll talk about each one of those separately. Okay, so when a tumor marker is a hormone, your hormones are produced in the endocrine system. So where do you think you're going to learn most of that information? On your endocrine test, by the way, it is the endocrine PowerPoint and also the thyroid PowerPoint. So you'll need both those PowerPoints in order to go the course. Now, I've had a lot of students say they have a lot of luck Googling something, so if they see a major word in the question or something, if they Google that word, sometimes that helps too. So there's different routes on that you can find. But I will tell you, I had a student one time that did nothing but the PowerPoints and got an 88. So she didn't read the book, she didn't Google anything. So they're in there. The answers are in there. So hormones are produced by the endocrine system. Beta-HCG, the beta subunit of, HCG, beta subunit, so beta-HCG. Germ cells, so the testes and ovaries. So why would we run an HCG on a female? Test for pregnancy, yes. Why would we run an HCG on a male? Yes. And I actually had a student sitting right there about 3 years ago, and when we were doing this lecture, her husband was about 27 years old, and they were trying to have a baby, and she peed on the stick, and it came out negative, and just jokingly, he said, here, I'll pee on the stick, and it turned positive. And lo and behold, he did have testicular cancer, and she said he was dead in 2 years. So, that's happened. So we have, at least once or twice a year, we'll have a phlebotomist come into the lab and go, why are they ordering this HCG on this man? He can't be pregnant. And you have to explain it's not a pregnancy test on a male. We're looking for testicular cancer. Testicular tumors, yes. Gastrin, your Zollin-Ellinger syndrome, that's also on your endocrinology test, and that's for gastronoma of the pancreas. Calcitonin, your thyroid, just calcitonin. And then again, your insulin, your C-peptide for insulinomas, which is your organ.
Pancreas.
Pancreas, you got it. Okay. So when a tumor marker is an enzyme, okay, so enzyme tumor markers. The main one here is your PSA. PSA is the only tumor marker used to screen asymptomatic patients. When a male goes to the doctor, and I'm not exactly sure what age they start, if it's 30 or 35, the male goes in to have his just annual physical or whatever, the doctor's going to order a PSA. It is the only one they will order just as a random screening for an asymptomatic patient. Okay. Prostate cancer is a very slow-growing cancer. They tend to capsulize, and so they don't tend to spread or metastasize. So that's why, again, they don't do it usually on males after 65, because you're probably going to die from whatever else ails you before you're going to die from prostate cancer. Sensitive and accurate is a tumor marker for detecting and monitoring prostatic cancer. It is important for the male in our classroom. It is very important for you females in the classroom who may have a male in your life. If he goes to the doctor for his physical and that doctor does a prostate exam, do not, and he gives you the order for a PSA test, do not run down to the lab and have your blood drawn. Because when he tests for the prostate, he massages the prostate, it will increase your PSA, and you will get a false positive. So you need to wait 3 to 4 days, okay? So don't go right down to the lab, because we have a lot of those that come down and then we just have to repeat them, because they had it the same day as the exam. So again, you got males in your life or whatever, and they go for that. Say, no, wait a few days. And again, you want to abstain from any activity or anything that could possibly cause that to be elevated, because it will. It's very sensitive test, very sensitive. Let's see. Lactate dehydrogenase is an enzyme that we'll talk in your enzyme lecture a lot. Alkaline phosphorbone and liver cancers, and then your neuroendocrine. Again, you're going to get those in a different lecture, so PSA on that one is the only one I'm really worried about. Slide number 9, CA19-9. It is an acylated Lewis blood group antigen. When we get into blood bank, we're going to learn, you know about the ABO blood group system, right? Now, you know you're probably an A positive or a B positive, so that's the ABO blood group system and the RH blood group system. But you're going to learn in my class, you're going to learn 23 blood group systems, okay, when you get to blood bank. And the Lewis blood group system is a separate antigen on your red cell. And so this one is just, again, it's a cancer marker, and pancreas is the main one, even though they have other ones here, but pancreas is the one I want you to remember for your ciliated 19-9. So yeah, now you're going to get in chemistry, and then you're going to hear about it again. Cancer 15-3 for breast cancer, and CA125 for ovarian cancer. So again, they're just going to order that test, and that's what it is that they're looking for. The questions on this test are very much just memorization. What tumor marker are we looking for? What organ is it affecting? So again, if you're a note card kind of person and want to have one on one side and one on the other to help you learn them, this really is just a lot, just memorization. Oncofetal markers, protein expressed during fetal development. Your alpha fetal protein is a tumor of the liver due to hepatitis or cirrhosis. Alpha fetal protein we're also going to talk about in another concept, because it is a protein, and in your SPE we'll talk about where it falls, and this is one that we can also use for neural tube defects in babies. So we're talking about it a little bit different here, but you will get it again in that lecture as well. Your CEA antigen, again, usually for colorectal cancer, but again, not really specific, but used for staging. And these are all, like I said, just memorization. In urinalysis, you're going to talk a lot about Bence-Jones proteins. It's a light chain protein that you'll find in your urine. So Jean's going to talk about that one a lot. Multiple myeloma will be a big one that you'll hit both in serology and in urinalysis. But with those light chains for your Bence-Jones proteins. IgM for beta cell cancer, Waldenstrom's macroglobulinemia. Again, you're going to talk more about that in serology than we do in chemistry. Ferritin we're going to talk a little bit about, but that'll be in your minerals lecture when we start talking about iron and things like that. So again, this one, there's not a lot of information, but what would make a good tumor marker? What are we really looking for a good tumor marker? What do we want it to be? Specific for an organ or tissue, right? We don't want it to be positive for everything. When we do that test, we want it to be positive for this organ, right? We want it to rise quickly when you have the disease, but we also want it to lower quickly when we've done treatment, right? And it's very hard when you get that order for CEA and you're walking into that patient's room and say, I need to draw your blood. And they're like, what are you drawing it for? And you can't tell them. And you know and they don't. All right? That's a hard one. But you can't. So what am I going to do with you? Have any questions at all?
Can you draw, or I mean, what analyzer do you do these on? Just any? Just a regular chemistry?
Who did the Centaur? Do we use them on the Centaur?
Tumor markers? I think so. I think I saw that.
It's on the Centaur, the one that she had. Yeah. A lot of them we send out, a lot of them we don't do regularly. Centaur was one of the machines that did that. It depends on where you're working, but sometimes the real special ones we don't do. Yeah, because you don't get that many of them. You'll do a lot of beta HCGs and you'll do a lot of CEAs and things like that, but some of these other ones you don't do very much. A lot more out there, but they've just slowly gone away because they really weren't very accurate. And they were just giving a lot of false positives, you know, and they're just freaking people out. So it's gotten actually a little bit